The work by Peter Lewis, excuse me, a clinical fellow at St. Michael's Hospital who's now returned to Wales, where he's taken up a consultant position. The Echelon primary femoral stem, I'm going to talk about that, why we use it, and the advantages and disadvantages of its use. Cementless hips, as mentioned by the previous speaker, have been in use for a long time. We've used them in our hospital for 30 years and have been pleased with them, but a number of registries, the Norwegian registry has shown a 4.5% failure rate with some cementless stems, and the Swedish registry has documented that in patients over the age of 50, cemented stems tend to outperform cementless stems in terms of survival. I must be pointing this at the wrong thing. There we are. However, the Swedish registry has demonstrated in 10 years that the use went from 3% to 16%, and in North America now, cementless stems occupy approximately 70-75% of the market. And this is tried to address loosening in cemented hips with long-term use. The Echelon primary stem is a cylindrical cobalt chrome stem with a 2/3 proximal porous coating, a collar, distal flutes, and a polished distal tip. The concept of this stem is one of diaphyseal as opposed to metaphyseal fixation, but we don't want distal ingrowth. Therefore, we have polished flutes distally. These flutes provide rotational stability without the potential for distal bone ingrowth. The aim of this study was to look at patient outcome and also overall implant survival. It was introduced in our hospital in 1998, used by 2 staff surgeons through a posterior approach. We have a prospective database for all our joint replacement patients, and we can retrieve the data on these patients without undue difficulty. So between February of 98 and March of 07, which was the study period, 428 patients received this stem. The follow-up is annual. You can see that the patients underwent testing of the WOMAC SF36 and the St. Michael's hip score. This lateral x-ray, you can see the advantage of this closed pin stem. You can see that it's closed up as the stem is impacted into the diaphyseal region of the femur, providing excellent fixation. 36 patients were excluded from this study, as you can see. That left 392 patients, symmetrical distribution of right and left, as well as 14 bilateral. These patients relatively young. The 87-year-old is not relatively young, but the mean age of 58 shows that these stems were used in patients with good diaphyseal bone, rather poor metaphyseal bone, but not bone quality that required a cemented stem. Nobody else seems to have this problem except the chairman. Here's the diagnosis. You'd expect the great majority were osteoarthritis. Acetabular components were widely varied, but you can see that the great majority, 91%, were uncemented reflection shells, and the liners were by and large standard polyethylene with a smattering of cross-linked polyethylene and ceramic. The follow-up, 42 months, 3 to 100 months. 1 patient lost to follow-up and 1 death 3 months after surgery. We had 3 patients sustain a femoral fracture after their hip operation. All 3 of these were as a result of significant trauma. We had 1 intraoperative fracture, and the rest of the complications are listed there. We had 9 dislocations, 3 requiring acetabular revision. So overall, our complication rate was approximately 9%, which sounds very high, but if you include all the complications that happen in your patients, you'll find that your complication rate is also between 8 and 10%. We had 5 aseptic loosening on the stem, 2 required revision, 3 retained. We had 3 acetabular revisions for instability, 2 deep infections, neither of which resulted in removal of the prosthesis. So our survival curve for aseptic loosening at 100 months is 99.3%. Revision for any reason at 100 months, our survival rate 98.3%. So this stem has performed extremely well in this selected group of patients. Outcome scores in terms of the WOMAC and the St. Michael score show no deterioration in the score after 1 year, and this is, I think, characteristic of most of these cementless hip replacements in younger patients followed serially. And the SF36 again shows no deterioration in the score after the first year after surgery. So there are a few reports of long-term performance of cementless stems, particularly a stem this design. This is a large prospective review demonstrating excellent long-term survival of this particular stem, and the scores have been significantly improved and maintained. This is a safe and reliable femoral component. This is only a midterm study at 8 years, but it shows excellent survivorship and excellent patient outcome scores. Thank you.